methodologies and the evidences, there are several papers that are in favor of one or other interpretations. Indeed, you may have invasive sampling with quantitative culture that were compared in certain studies to the endotracheal aspirate with semi-quantitative culture. Or you may have invasive sampling with quantitative culture compared with the qualitative culture of the endotracheal aspirate. But indeed, we do not have any trial that compare the non-invasive sampling with quantitative cultures to non-invasive sampling with semi-quantitative culture. So the conclusion that sampling technique does not affect any clinical outcome, including the duration of mechanical ventilation, the ICU length of stay, and the mortality. Then if you look at the microbiology methods in the recommendation of the ISTA published and ATS published in 2016, you may have several options. The bronchoscopy with quantitative culture results, the endotracheal aspirate with quantitative culture results, and blind respiratory sampling with quantitative or semi-quantitative culture. So several options. But when you look at the final recommendation from these different opportunities, there is a weak recommendation that tells us that is suggested non-invasive sampling with semi-quantitative culture to diagnosis of EAP. As you may know, there are different opinions and attitudes from two sides of the Atlantic Ocean, and in general, just following the French school, most of the European countries are in favor of the quantitative culture, whilst in the other side of the ocean, they're quite open also to qualitative cultures. However, even we want to have a sort of invasive sampling. We do have the bronchoscopic guided sampling versus the blind sampling by using telescopic catheters. The problem with the telescopic catheters that are quite popular because you do not need special experience, whilst you need to have a good operator when you use the bronchoscopic catheter, that there is no guarantee that the material that you are collecting is indeed originated into the segments that is responsible of the attributable to the segment that is responsible for the infection. So the role of the segment identifying the area where I should sample my sampling through the CT scan or through the chest X-ray may be not sufficient. Indeed, when we select the sampling area, this is in general based upon the location of a new progressive infiltrate on a chest radiograph. This has been told several times during this session. Or you can visualize the segments where you may identify purulent secretion with a bronchoscopy, for example. There are some buts, because the accuracy of the chest X-ray in predicting the presence of EAP is relatively limited, and at times you may have opacities or densities that are related to other phenomena. And if you look at the idea of just sampling in a blind way, there are some post-mortem histological studies that confirm the possibility that VAP is often a bilateral, a multifocal event, when much more than you can see in the chest X-ray or in the CT scan. And the post-mortem studies have, however, a major limitation, because if you want to just rely upon them, you always have to keep in mind that these are more representative of terminally ill patients with VAP, where there is a possibility of a diffusion of infection which is much higher with respect to those patients, for instance, that are prone to survive. So we just try to better analyze how, by using the bronchoscope, you may have a concordance between specimens taken in the two lungs. But if you look at the literature, you can see that this concordance varies a lot, widely, from 53% up to 92%. Why is so? Because in these papers, in this study, they use the same bronchoscope in most of the study, and just giving the possibility of a cross-contamination, getting a higher rate of concordance that was indeed untrue. And the blood samples that are taken from certain areas may be a reflection of what is the evolution of in certain and different stages in a specific area more than the broader phenomenon pneumonia. And there is a low concordance can be also the reflections of the difficulty to repeat reliably the quantitative blood culture. What we have done, we have just accomplished a study to determine whether the choice of the pulmonary sampling may be clinically also relevant for the management. And we enroll something like 79 patients in the ICU, and where we perform with two different bronchoscopes the bronchoalveolar lavage in the two hemisystems. And the primary endpoint of this study was to find out if there was a microbiological concordance between the right and the left culture taken by the right and the left brainstem. The blood culture have given these kind of results. 21/79, then the 70% of the patients had a bilateral negative bronchoalveolar lavage. In 46% of them, it was bilaterally positive, and in the remaining proportion, in 12 patients from the right stem and in 10 from the left side, were unilaterally positive. And the intra-concordance observed for the patients was relatively low, no more than 60 cases. And if you look at this table where there was a correlation between the radiographic findings and the blood culture results, the presence of the radiographic infiltrate in the sampling area predicted the VA culture positivity with a positive predictive value only of 61%, so not very much. We had an additional part of the study where we tried to propose the different results of the studies together with the other clinical indicators to a team that was composed by an ICU physician and an infectious disease specialist in order to see if there was concordance depending upon the kind of background the two physicians had. And in general, what has been shown that the treatments that were chosen based on right or left culture alone were as appropriate as those based on the bilateral data in more than 90% of the cases. So, can be true to a specific situation we have in my hospital where the broad spectrum drugs are often used because we do have, unfortunately, like many other European or Southern European countries, a high proportion of multi-drug resistant bugs and polymicrobial infections. However, we just like to conclude that from these studies, the idea of just sampling from the right and the left lungs indeed yielded a very low microbiological concordance. So this is an additional question mark, I would say. And at times, the single respiratory sampling provides an incomplete assessment of the lung microbiology when the VAP is suspected. However, very often, the experience of the physicians and the specialists may be appropriate also in looking at the presence of the infiltrate and just predicting the positivity that is relatively low, but in the end suggesting that also the simple sampling, regardless the opacity that can be detected from the chest X-ray, can be a reliable way to approach the diagnosis, the microbiological diagnosis, in a quite reliable way. What we do in our institution, that in general we use the blind bronchial barrel lavage, or to less extent the endotracheal aspirate, but still, as mentioned by the previous speaker, we use the bronchoscopy for selected cases where the patient had escalated lesions, lung abscess, or specific suspicions. Thank you for your attention.